So welcome everybody. Just going to give it another 30 seconds to see if we get any more people joining us, and then we'll make a start. Okay, let's get going then. So hello, thank you very much for joining us. My name is Helen Brown. I'm Deputy Chief Exec here at West Herts, and today we're going to give you an update on our Your Care, Your Views engagement and what we heard in the first phase of engagement. So the normal Zoom rules, microphones will be kept muted. If you can keep your camera off, that helps us with bandwidth. If you want to ask us a question, please use the chat function and send it to West Herts Communications, and only the host will see the question. And we are recording this session and it will be made available on our YouTube channel after today. So as I've already said, the aim of the session is to share feedback that we received during phase 1 of engagement, to provide a bit more information on issues that we were told were important in phase 1, or clarify where it wasn't as clear as it could have been. We're going to go through which services are moving between sites and which are staying. We're going to tell you how you can get involved and share your views and give an opportunity to ask questions. So as I hope most of you are familiar with from phase 1, our vision is for our new and redeveloped hospitals to each have a distinct role, working together to provide really comprehensive range of hospital services for local people. So Watford will be the emergency and specialist care site. St Albans will focus on planned surgery and cancer care, but we'll also have an urgent care service currently being worked through by the CCG. And subject to separate engagement later in the summer. And Hamel Hempstead will continue to provide urgent care services and have a focus on planned medical care and long-term conditions. And all sites will have some outpatient services. So in terms of headlines from what we heard from the first phase of engagement, we heard from people that the idea of one-stop clinics was popular and something that people would welcome, particularly the opportunity to have diagnostics at the same time as outpatient appointments where that where that makes sense. We did hear about travel being a concern, but overall people living in Dacorum and St Albans are happier to travel between hospitals in those areas than to come into Watford, so happier to go east-west and west-east than north-south. And likewise, residents in Watford and Three Rivers would prefer to use Watford if that's possible. If they need to come to Hamel or St Albans, there's no strong preference as to which one. We heard through the engagement that people are concerned about the state of our buildings and the need for new buildings. And we heard some kind of concerns raised with us about healthcare being delivered online. And this was reflected in both the survey and the engagement meetings that we held. So in response to that feedback, what we're doing at the moment, we'll be providing some case studies from a patient perspective, which try to bring to life some of the new models of care that we're looking at, particularly for outpatient services. For example, the proposed way of managing routine follow-up appointments, which we call patient-initiated follow-up. We do want to reassure people that in-person appointments will still be available, and it's not compulsory to use virtual appointments or online appointments, so we will be offering choice. Obviously, that is subject to the COVID situation. We are going to be carrying out some more targeted research to determine whether the feedback we got from our survey, which was largely a self-selecting sample of people responding to the survey, is mirrored if we take a more representative population sample. So we've engaged some market research to help us with that. We'll be conducting some more in-depth research with current and recent patients whose services would be moving under our proposals to understand in more detail what those concerns are and how we might be able to address them. And we're going to be continuing to have conversations with as many different people as possible and trying to broaden and deepen our reach through community networks. And we are setting up a travel and access steering group and a reference group to pull in partner organisations, including local councils, for example, to work with us to see what we can do to improve access to our 3 hospital sites. So I'm going to hand over to Freddie now, who's going to talk you through the clinical model.
Hello, my name is Freddie Banks, and I'm a consultant urologist here at West Herts. On the Hamel Hempstead site, we plan to make our key medical centre. So we are increasing the technology available at Hamel Hempstead Hospital from a diagnostic capability, so that we will continue to have MRI, but it'll be a new MRI scanner, CT, and we're also putting in DEXA scanning there, which is very important for particularly the rheumatological specialty. The emphasis here as well is to try and streamline patients' care so that we have more one-stop clinics. These are to integrate your diagnostics and coordinate your appointments so that ideally you can actually have your diagnostics on the same day as your appointment. The other key component here is that we're very aware that so many patients have multiple comorbidities, and from a secondary care point of view, we want to have better integration between the specialties that are looking after patients. So that's an example with that would be a patient who is diabetic, who's also got cardiological issues and potentially some rheumatological issues, that we can actually coordinate all of those specialties looking after the patient, rather than a patient coming up to see the cardiologist, coming up another time to see the rheumatologist, and another time to see the diabetologist. So that is a key component to how we see the services changing, and the structure at Hamel Hempstead Hospital will be to support that. In conjunction with the planned medical component, Hamel Hempstead Hospital will continue to deliver urgent care, which will be supported obviously by Watford, but that will continue at Hamel Hempstead Hospital. Next slide, please. In conjunction with the one-stop clinics, we also want to try and have much better integration with primary care, so that patients can be looked after better in the community with support from hospital consultants. But similarly, when you do need to be seen, we can get you up to the hospital. I appreciate there's a lot of anxiety about things switching too much to online and the loss of face-to-face appointments. But I think COVID has taught us that we can actually manage a lot of patients at home without having to be seen. A good example of this is our COVID hospital that we ran during the COVID pandemic, which became a national exemplar. But the respiratory team had 600 patients that they were monitoring remotely at home, who had saturation machines and were being contacted on a daily basis to record what their oxygen saturations were. And then if these were deteriorating, those patients would then be called up to the hospital for face-to-face consultations. So that just gives you an example of the scale that is actually achievable with some of the remote monitoring. And I think that will become a new model of care, that patients will be much more involved with their own care and be responsible for it. But again, it's access when you need it, rather than just because we booked you for a 3-month follow-up appointment. In conjunction with the services and the better integration of the services, we'll be revamping the hospital so that it's a much better flow for both patients and staff within the hospital. And finally, a key component for the rheumatology service is that the DEXA scanner, which is currently at St Albans, will be moved across so that that would support rheumatology being based out of Hamel Hempstead Hospital. And here are the list of services that will continue to be run from Hamel Hempstead Hospital. Indeed, this will be the main base for the majority of these services. So if Hamel Hempstead is our medical centre, then St Albans Hospital will have a primary focus of planned surgical care. Again, this will be supported by an increase in the diagnostics, so that we will have MRI, CT, nuclear medicine, all available at St Albans. So there's effectively a full remit of diagnostics, with a view to streamlining the diagnostic pathway, predominantly for cancer, but also for non-cancer diagnoses. There'll also be an emphasis on the cancer support services that will be condensed at St Albans. The other key component of St Albans is that it is our elective surgical site. I think everybody is aware that quite often elective surgery gets cancelled, typically because of beds have been lost to emergency patients who come in overnight. One of the key components or advantages, rather, of having an elective surgery site away from the main emergency centre is that the bed base doesn't get contaminated by emergency admissions. So this means that when we give you a date for your operation, it should absolutely be that is the date that the surgery gets carried out without it being cancelled on the day. In support of condensing the services there, endoscopy will be rebuilt at St Albans, and also there will be a urological one-stop unit. The key advantage of having endoscopy is co-located with general surgery. Is if you are diagnosed, for instance, with a bowel cancer, you've then got the opportunity to see a general surgeon and your further treatment being managed. I think it's that sort of model that is so much better for patients in reducing anxiety. There's nothing worse than leaving your hospital, having got a diagnosis, and then wondering when you're going to be contacted, what's going to happen. If we can streamline all of this effectively into one-stop clinical services, then I think it'll be a huge improvement for patients. It's obviously it'll be much easier for patients because everything will be under one roof. Instead of running between Hamel Hempstead for this scan and an appointment at St Albans and back to Watford for another scan, it'll all be as a single point of reference in one hospital. Another key component of having an elective centre is that you can really sort out the infection control because you haven't got emergency patients being admitted with either chest infections or some form of infection that then becomes an issue for cross-contamination with elective patients. That's particularly important for things like orthopedics, where joint infections after hip replacement is a life-changing complication, and it is absolutely essential that we have very, very low rates of infection. And then in conjunction with the services, we again hope that lots of it can be day cases and generally a much slicker and better experience for both patients and staff alike. Here is a list of the services that will be based out of St Albans Hospital. So returning to Watford, very aware that the estate at Watford is in particularly dire states and simply does not work as a functional building in terms of delivering emergency care. So the focus of the rebuild of the Watford site is that we hope that the vast majority of buildings will actually be new builds, but we will have a hospital that is effectively designed around a patient coming into the hospital as an emergency. So we will have complex diagnostics available and a much better flow of patients through the hospital with all of the specialties really dividing their time into treating the emergency patients, which will be based at Watford, and then having effectively a separate half of their service either at St Albans or Hamel Hempstead Hospital, delivering the elective component of whatever service they are in. The other key component of Watford is that we will have a completely new women and children's, won't actually be a building, but it'll be part of the main hospital, but floors, so that the birthing experience will be totally different. We'll have ideally an expectant mother would actually come into the hospital, into a room where she will stay for both antenatal care, the delivery and postnatal care, rather than being shuffled through an antenatal ward to a delivery suite and on to a postnatal. So I think the experience for mothers will be hugely improved. And that will follow on as well with integration with the paediatric component, so that the neonatal intensive care unit, again, will be hugely expanded with a much better experience for mothers. It's very, very crammed at the moment. And we will have a spacious and properly built neonatal intensive care. Next slide, please. The way that we run the emergency area, the key component here is that the staff will move to the patient so that you can be reviewed. There'll be a much greater emphasis on assessment. Really, that patients being admitted to hospital actually should be really seen as a failure, that the key component that you want to do is to try and manage as much as you can in the community to try and prevent patients coming into hospital. You want to be able to appraise them when they come in to try and avoid hospital admission. It shouldn't be that you come into hospital to get sorted. We should be in a position that we're actually sorting you out before getting into hospital or when you actually come up, rather than simply just plonking you in a bed and then sorting out everything after that. So that is a key cultural change that we will try and deliver at West Herts, and we will have a building that actually facilitates that type of medicine. Just coming back to the paediatric services, again, this will be, I think, hugely improved. We will have an expanded and improved children's emergency department with much better access to the paediatric ward and paediatricians. Again, it's all designed just to try and get the patient experience better and the flow of patients better. One of the huge advantages of having a rebuilt building is that we can have a much higher percentage of single rooms. So we'll be looking at having probably in excess of 70% of rooms as single rooms. So these will all have their own bathroom, fully en suite. And then this actually means that we can get the ventilation and the infection control much, much better, so that we avoid patients being cohorted with other patients who may or may not have infections, which is a continual challenge for us within the hospital. The new building will have a big emphasis on being environmentally friendly, and there may be a commitment to actually be a completely net carbon zero over the lifetime of the building. The aim is to have, I think, every room with natural light, and it'll be a much more spacious building, which will be much better for the patient experience and also for the staff experience. And then every specialty has an emergency component, so every specialty will continue to have a presence at Watford Hospital. Right, I'm going to hand over. I'm going back to you, Helen, or no, Esther.
Yes, thank you, Freddie. So just to quickly recap on some of the main changes and benefits, the areas that are most affected by how things move between sites are our diagnostic and outpatient services, but very much with the aim, as Freddie has described, of making sure that the pathways for patients are improved and are logically and sensibly arranged so that we can do as much as possible in one visit. I think it's really important to note that as well as that working better for patients, it really helps staff with improving their opportunities for supervision, team working and development. And it's been shown in research that feeling part of a cohesive team is really, really important for staff, for their well-being and also for clinical care. The next few slides that I'm going to talk through in effect cut the information that Freddie has given in a slightly different way, just so that you can really clearly see exactly what moves from where. So they're the sort of slides that when you look at them, the headlines will jump out. So I will go through them fairly quickly. First of all, thinking about what moves between Hamel and St Albans. So moving from Hamel to St Albans are those surgical specialties. And as Freddie described, that's very much so that surgical care and cancer care is very much focused on the St Albans site. And the other services that are listed there, nuclear medicine, endoscopy, cystoscopy, they very much have a cancer element to those services, which is why it's more sensible for patient pathways that they are based at St Albans. So moving on to our east to west move, services from St Albans that will focus on the Hamel and the Watford sites are all the medical specialties, cardiology, dermatology, etc. So for all of these moves, thinking of the St Albans and the Hamel sites, the intention is that there's a service at Watford, but then it's one of the other two sites so that we can really plan care and coordinate it and make sure that teams are together. And as you heard earlier from Freddie, the DEXA scan will be there at Hamel Hempstead Hospital because that's very much important to the rheumatology care pathway. Next slide, please. Okay, so the main theme of this slide is what is currently being provided on the plan care sites, which would go to the Watford site, and why is that? So our fracture clinic, as a result of COVID, has moved locations, and the intention is that that is best located near to the emergency department at Watford. Already over the years, the model has changed quite a lot for the fracture clinic, and they already have a really developed virtual service so that they can make sure that when they do bring patients back in, that it's those patients that absolutely need to be seen by specialists, they need to be seen quickly, and to make sure that they get to see the relevant orthopaedic specialist for their particular injury. Next slide, please. Okay, so there are a few specialties where to make sure that we've got the volume of care that means that we can really focus and wrap around and provide that integrated care model and make sure that we've got clinicians readily available, that we would need to make sure that we have a greater service on the Hamel Hempstead site. So the specialties that you see, diabetes, rheumatology, cardiology, respiratory, the intention is to build the service at Hamel so that that integrated care model, that ability to see the specialists that are needed for you individually can become a real possibility. And then for orthopedics and spinal surgery, what the intention is there is to make sure that we've got a hub very much based at St Albans, because again that fits with the plan to have our elective, our planned surgery continuing on the St Albans site. So these last three slides talk about services that will not be moving. So where we've got services that we expect to continue to provide at all 3 hospitals, so gastroenterology outpatients is one that we expect to continue across all sites, because it has links both with long-term condition care, but also with the endoscopy service and the cancer service at St Albans. So it's a service that sensibly fits across the 3 sites. And then, as you can also see, obstetrics and maternity, again, we know that it's very much a service where women tend to attend their local hospital, and that's something that we want to continue to provide. And again, diagnostics across all 3 sites. Looking at the services that we've got at Watford and Hamel that we continue to provide there, I think we've covered those in previous slides. And then outpatients that continue at Watford and St Albans. You can see that there's a range of specialties here that are already on those 2 sites. And thinking particularly about the St Albans site, our breast surgery and mammography will continue to have Clch as its main site as at present. And then finally, it's really important to note the diagnostics across all 3 sites. So we're really keen to make sure that we've got the complex diagnostics, MRI, CT, across all the sites, so that we can make sure that we can have one-stop pathways, whether it's for long-term condition care or for surgical care, and with fluoroscopy also being available in the future at St Albans. So back to Helen for our engagement plan and timeline.
Thank you, Esther. So yes, just to remind people that we're currently in the 2nd phase of engagement. So we engaged in March on the plans that we're talking about today, and we had a pause during April for the local election period, and this is the 2nd phase, which launched a couple of weeks ago. Now we're running through to the end of June with meetings like this online, specific invitations to meetings that we're also going to. There is a feedback form for you to give any views if you didn't complete the survey or feel you've got extra things that you wanted to say. And as I've already highlighted, we'll be doing some more detailed interviews and a bit more survey work just to round out what we're hearing in this process. And then all of that will be gathered together and fed back to Trust and CCG boards as we finalise our clinical strategy and the clinical brief for our redevelopment. So this is just information on how you can get involved. So on our website are all of the documents from phase 1 of the engagement. This new document here, which is just the summary of what we heard in phase 1 and a bit more detail around the services that are moving. The deadline for the feedback form is midday on the 30th of June. And there are lots of opportunities. Obviously, we're preaching slightly to the converted because you're on the call today, but there are lots of opportunities for people to join sessions like this. So I think I will leave that slide there. And now we get to go into the question and answer session. I am missing Louise today, who's our Director of Communications and isn't well. She normally does a great job with the Q&A, so I'm going to have my first go at Q&A, and I also know that Esther's also got a dodgy throat today, so we're going to try not to pass too many questions to Esther, and between myself and Freddie. So far I've got about half a dozen questions. Do send any more in, but I'm going to start by asking Freddie if he could please pick up a question about dialysis. So the question says, a friend of mine who lives in Croxley Green has recently had a fistula inserted into his arm at Watford in preparation for dialysis treatment in the future. He would like to know how, if at all, the current proposals will impact on his future dialysis treatments. Freddie.
Okay, thank you, Helen. Well, dialysis at West Herts is actually provided by to our external providers. So the Hammersmith Hospital actually provides dialysis services on the Watford site, and Eastern North Hearts provide satellite dialysis service at St Albans. So the St Albans service, there will be no change as it stands at present. On the Watford site, I hope that the dialysis centre dialysis will continue to be provided, but it'll hopefully be in a new building and not the 1834 workhouse building. So I hope that it will be a very significantly improved unit for dialysis, fit for modern day dialysis. But at present, the current arrangements with the Hammersmith Hospital will continue as is at the moment. So, but we will, the need for dialysis at West Herts has to continue. So your friend in Clch Green will not be having to go elsewhere for their dialysis. It will be provided on the Watford side.
Thank you, Freddie. So I'm going to pick up the more clinical questions first, and then we'll see how we're doing for time. So one of the questions come in says, it's not convinced on, my sense is the strategy does not give sufficient consideration to new models of care, specifically virtual consultations. We've seen rapid advances in capability and acceptance during the pandemic. Could this opportunity be reassessed? So before I hand that again to Freddie, I just want to say something about this. What we've talked about today and what we've focused on today is specifically the moves of services between the sites in line with our strategy to give each of Hamel and St Albans in particular a very strong focus. In our phase 1 engagement, the engagement document did talk more about how outpatient models of care are changing, and they are changing, and they've changed rapidly during COVID, and we expect them to continue to do that. If this is your first kind of real interaction with it, that might be why you think we focused a bit on location and not enough on service model. But one of the pieces of feedback we had from phase 1 was, well, that's all lovely, we understand about these new models of care, we just want to know what's going to be delivered from where. So we're trying to do a bit of both. Freddie, do you want to talk a little bit about how outpatient services are changing and what our plans include?
Yes. I think obviously COVID has really challenged us how we deliver care. And I think my own direct experience of this is that there's a time and a place when doing things virtually does not work. So I think there's a sort of public perception that we're going to do everything virtually, and that is categorically not the case. There is a time when we really do need to see patients, and it's obviously, if you're having to examine a patient, then it's absolutely critical that that patient comes in. However, I really do challenge the number of times that we bring patients back up to hospital to have results. Prior to COVID, we'd already switched a lot of our results in my own specialty to telephone consultations. And I think, and that's been accelerated with COVID, so we've done more of that. And I really do feel that we should really aim to only try and bring a patient up to the hospital once, which ideally should actually be for your diagnostics and a consultation. And the rest of it, I genuinely believe most of it can be delivered virtually from the comfort of your own house, either on a video format or even just by telephone. So I think that is the model that we are looking for. And I'll just come back to the COVID hospital that we had. That was, say, at its peak, that was 600 patients a day were being managed remotely. Imagine if we'd had to try and monitor that number of patients coming up to the hospital to record their oxygen saturations and pulse and that side of things. It would have been totally unmanageable. And that sort of model now lends itself quite well to things like heart failure, where we can monitor patients remotely. And actually, if everything stays stable, absolutely fantastic. You just keep monitoring yourself at home. And we need, I think patients will become much more involved with their own care. And we will look to have different models of access so that patients, when they are aware of themselves deteriorating, have better access to the hospital. But similarly, if you're stable and everything is going well, then you don't come up. So it's going to change, but I think it'll be very, very much for the better. And my aim always is just to minimize the number of times that a patient comes up to hospital, and also maximize the experience when you come up to the hospital. When you come to the outpatient appointment, ideally you should get a proper opinion and diagnosis at that appointment. That shouldn't be the sort of start of investigations and the start of a pathway. We should aim to be that is effectively the end of the pathway, that we've done the diagnostic workup. This is what you need to do, or if you need to go onto an operating list, that's the point at which you go onto the operating list. And my hope is that we can really streamline all of that so that the hospital is really giving you the opinion and the diagnosis that you need at that face-to-face consultation or at that consultation. So it's going to change, but I think it's actually for the better.
Thank you, Freddie. So a number of questions coming in. I'm going to pick some of them up and then see whether Freddie and Esther want to add anything to them. So I'm in no particular order. Some of them are more straightforward to answer. So one that's just come in around haematology. I see my haematology consultant at Watford. Is this department staying at Watford or moving out? That's a quick answer. There will continue to be a haematology service provided at Watford in the future. And obviously we hope that if the plans for Mount Vernon Cancer Centre do come through, that will be a great opportunity to really develop and strengthen the haematology service at Watford. Another question, which is about the focus on our 3 hospital sites. So the question says, agree that emphasis should shift to preventative support and care in the community. Why is the focus in these plans so heavily constrained by existing hospital sites and on services based in these existing locations? Other trusts, for example, Hampshire, are exploring creating multi-use facilities in the community where people are, instead of expecting people to travel some distance and inconveniently to a hospital location. So again, some of that has been picked up a bit by Freddie. We are absolutely planning to change and develop services. This presentation does focus on what services will be provided from each of our current 3 hospitals and where there are specific changes in that, because we were asked to make that completely clear and transparent in this process. There are quite a lot of services and a lot of work has been done over the last few years with Harts Valley Clinical Commissioning Group and other providers to take more services out into different settings. So ophthalmology, parts of the ophthalmology pathway now delivered in optometrists in the community, gynecology. There are a number of services that have developed, and we will continue to work with community providers and GPs to look at opportunities to do that. For us, there's something about, as well as the virtual consultations that Freddie's just described, our specialist consultants providing advice and guidance, our general view now is that if you need to be seen face to face, you need to see a specialist, and you're quite likely to need specialist facilities and diagnostics. So it is still important that we organise our services in a sensible way, that we make the best use of our clinicians' time by not spreading them too thin, and particularly we focus on getting the right diagnostics in the right place to complement the pathways that we're looking at. So we think it's actually quite a good opportunity, because we've got the 3 hospitals in what's a relatively smaller geographical area to have a really strong diagnostics offer for the community and really strong specialist outpatient services to support them. But it's not that we don't do anything anywhere that isn't one of those 3 hospitals, or that we're not open to continuing to work on different models of care. And another good example, I think, would be diabetes, where we have a joint community diabetes service that we run jointly with Hertfordshire Community Trust, where the majority of diabetes care is delivered in a range of primary and community settings, and it's only the more specialist or complex face-to-face work that comes into a hospital site. So I'm going to pause there and just see whether Freddie or Esther want to add anything. Don't feel you have to, but if you want to, please do.
I think we're actually quite lucky to have the 3-site model in it, because I think it means that we can have properly equipped diagnostics, which I think places like Hampshire will struggle to provide the level of diagnostics that we are going to be capable of providing on 3 different sites into satellite centres. And then you will be back into the problem that we've historically had here, that we've had some of the diagnostics available on one site, some of it on another site, and then you don't get a coordinated care model. So, good luck to Hampshire, but I think we're actually paradoxically in a rather stronger position, because we will have radiology support and diagnostic support at a high level on all 3 sites. So which will be accessible. And then there's just the question of the integration with the community, but it's easier when you've actually got the base of the diagnostics on all sites.
Okay, thank you, Freddie. So I'm just looking through the questions to pick up any other clinical questions. There is one here which says, can we confirm that the only remaining beds in Hamel Hempstead, now run by CLCH, which is Central London Community Health, will close next April? How can Hamel Hempstead be described as a hospital if it has no beds? So I'll pick up the first half of that question, and then Freddie, I'm going to come to you on the second part. Currently, yes, West Herts Hospitals Trust doesn't provide any inpatient care on the Hamel Hempstead site. CLCH, which is the community provider, are reviewing their current model of community beds, so rehabilitation and step down beds, and they will be, as I understand it, engaging on that on those services throughout this year. Our assumption at the moment, however, is that there will not be beds on the Hamel Hempstead site, but we are open to reviewing that position, subject to the outcome of the work that CLCH do, and look at options if it was a view that Hamel that they needed or wanted to provide community beds on the Hamel site, then we would work with them on that issue. So Freddie, hospital with no beds, can you have a hospital with no beds?
Well, I think you can have a hospital with no beds. I think again, it comes back to the sort of the model of care that we aspire to. And I think getting away from the crisis management of a patient deteriorating, ending up in hospital, and then having a very prolonged recovery needs to be sort of flipped on its head. That if we can integrate much better between primary and secondary care, there's a lot that we can do in the first place to stop that patient ever setting foot in the hospital. That means having effectively a multidisciplinary service that integrates not just between your GP and, for example, a care of the elderly consultant, but we have support with occupational therapy, physiotherapy, to try and prevent that patient ever coming into the hospital. And then I think as well, we can then do a lot on discharge, so that we've got, again, much better integration for a patient coming out of hospital, so that there isn't the need all the time to have sort of intermediary beds that we know that patients spend a lot of time in and take up a lot of bed days. So I think there's a lot that we can do. And I think you can still support that from a hospital building, even if it hasn't got inpatient beds. So I think it is absolutely feasible to have and to be able to call it a hospital, even though you don't have inpatient beds.
Thanks, Freddie. I mean, I think my definition of a hospital is it's a collection of specialist expertise and specialist facilities to provide healthcare. And I think on that basis, Hamel and St Albans both meet that definition. And beds are not required to provide great specialist healthcare, although sometimes they obviously are, but not always. So I've got I think that's all of the clinical questions or the service model questions that have come up. I'm just going to answer this one that's quickly pinged in. Is CLCH a privately run organisation? The answer to that is no. It's an NHS organisation based in London that provides community health services across quite a wide number of areas. So I'm going to move on now. There's a couple of questions regarding the engagement process itself, and then there's a couple of questions that really relate to the broader redevelopment. And although this engagement process is really around the clinical model and the clinical brief, I will pick up some of those questions at the end. So in terms of the engagement, there was a question about making sure that any further work we do on the survey, which I described as a representative sample, make sure that how will we make sure that hang on, I'm just looking for the actual question on my list now. How will we make sure that the views of people who are the main users of health services are not overshadowed, let's say, by a view of the general population? So yes, how will it take care to reflect the views of those with the greatest personal interest in the issues? Frequent visitors, older people, those with mobility problems. Otherwise, a distorted view on issues such as accessibility will be obtained. So I think it's important to say that this extra work that we're doing at the moment on the survey isn't intended to override what's already been done. What we've heard some really important feedback from the survey to date. It's really just to add some richness to see if we can catch groups that we didn't capture in that process and understand their views. So we have relatively fewer responses from younger people or from people with families using maternity services, and a relatively higher response rate from older people or people with long-term conditions. And it's not to say that what we've heard through those groups isn't really important. We're just trying to make sure that we reach the widest possible range of people with an interest in health provision. And actually, we will then look at the feedback in the round. It won't be a question of saying, well, those people aren't bothered about access and therefore access isn't important. It will be just to give us a rounder view, or as round as view as possible as we can get, and just cross-reference. Another question on the engagement process was, hang on, I'm just looking for it. Oh, okay, how many individual and organisational contributions have been made during the current period of engagement, and is there a list available of the organisations which have made submissions? And I think the quick answer to that is we know how many responses we got to the survey, which was just over 1,600, if I'm right. We know how many people joined online meetings such as this. We know how many hits we've had on our website. What is actually really difficult to do, though, is to say how many individuals does that represent, because one individual might have attended many meetings or gone to look at the website on a number of occasions. And it's not possible to track it back to an exact number of individuals. And again, in the main, in the first phase of engagement, it may be that we need to follow this up, and when we publish our final report, we will do our best to make this clear. Largely, we haven't had organisational based responses. We've had responses from individuals, although that's not to say that we haven't had a few responses that are on behalf of local groups. So I'm afraid I can't give you more than that, although there was a brief update in our board papers last month, which did give some information, and when we publish the full report, which we expect to go to our July board, as long as nothing changes from here, we'll give as much detail as we can on that. So I'm just having a look at time. Yeah, we've got a little bit of time left, so I'm going to pick up a couple of process questions, even though they're not exactly the focus of the engagement process, your care, your views. And broadly, I'm going to say they fall into, there's three sorts of questions that have come in on this. A question about shortlist versus preferred option, a couple of questions around timeline from here, and a question about money. So I'm going to take the first one, which is shortlist versus preferred option. And somebody eagle-eyed has said that in our latest engagement document, we've referred to shortlist for the first time since October, whereas previously we talked about preferred option. And I honestly, I haven't got it in front of me, so I can't go back and say exactly what did we refer to. But to be clear, that in October, we did agree a shortlist for detailed appraisal, and this is around the redevelopment particularly, and what the options are for that. And the shortlist included 6 options at Watford, on the Watford General / Watford Riverwell site for the redevelopment of emergency care, on a spectrum from business as usual, which is an option we have to include as a comparator, do minimum, through then a range of options all the way up to effectively all clinical services in a new build facility on the Watford site. And we've pretty much said, well, for quite a long time, but certainly in October, our preferred option, our indicative preferred option, subject to the detailed economic appraisal, would be to deliver as much as possible new build emergency care facilities on the Watford General / Watford Riverwell site. And then we had 3 options each for Hamel and St Albans, which again were a spectrum from do nothing, do minimum plus. And really those options are about estate solutions and how much capital investment we can make on each site. And what was effectively all of those options involved our preferred way forward of retaining the 3 hospital sites, and our priority focus is on improving emergency care and specialist services, because those are the services that the most unwell patients use, and for the longest periods of time, and also because the estate at Watford is in particularly poor and unsuitable condition. So that hasn't changed. We are still doing the economic appraisal. We're still finalising. It is really complex, detailed work. We're still finalising that with a view to then completing the economic appraisal and making a formal decision on our preferred option, which really says this is exactly what we want to do, this is what we think it will cost, that forms the basis of the outline business case that we then submit up through the system, so through the Department of Health and what's now known as the new hospital programme for funding. So apologies for any confusion there, but it's not a revisit of the shortlist. Our preferred option will be based on our 3 sites. So this engagement process, your care, your views, has all been about, okay, we're expecting to redevelop on our 3 hospital sites, invest in improving the buildings. Let's be really, really clear what our clinical model is, what services we want to deliver from each site, so that when we design new facilities, it always needs to come from that clinical perspective of the services we want to deliver. It's not about new buildings for the sake of new buildings. It's new buildings to support delivery of care. So then a couple of questions on timeline and budget, and these are the trickiest ones to answer, I think it would be fair to say. So whenever we do a business case, and people who've been on this journey with us for some time know that we have been working on this for some time. Part of the business case, you have to set out what you expect to happen when, and that informs the costs, and it informs the inflation assumptions and all sorts of things like that. And we always do that with our best view of what we hope to be able to achieve, and always with the view as making progress as rapidly as we can. Our current timeline for the outline business case is we're still looking at completing that for approval by our trust board and by Herts Valley Clinical Commissioning Group and NHS England kind of local regional teams, hopefully before Christmas, and then it would get submitted to the new hospital programme and the department for consideration from there. I think it's worth saying though that the new hospital programme, which is now part of the Department of Health and NHS England, their responsibility now is to deliver, I think it's 48 either new or substantially redeveloped hospitals by 2030, and that's their task that's been given to them by the government. Have got a huge job on, And one of the things that they're trying to do is get more standardization across the programme, and also make sure that best practice is clearly set out and shared. Think about the construction market. So it's all very well to say we're going to build 48 new hospitals, but we need to, the new hospital programme need to be confident that there are contractors out there to deliver that programme. They're also really keen to look at what are called modern methods of construction, where there's more kind of pre-assembly of building components that are then assembled on site, and with that you get some benefits of scale, economies of scale, and of programme. But what it's meaning at the moment, as the new hospital programme kind of pulls all that together and gears up, is that local programmes such as our own are having to keep really close to the new hospital programme to understand their expectations, but also work with them to be clear on timelines and the like. So we are, that is still not being finalised, and we are expecting to continue that dialogue with the new hospital programme. And I'm just putting out the kind of little flag here that says that it may change, because it may be that the new hospital programme come back to us and say, well, either we want you to do it faster, which would be tough, but we'd give it our go, or they might say, actually, we won't be ready to look at a business case from you until a bit later, or we want you to think about this thing that you haven't thought about before because we never asked you to, and therefore you'll need to do some more work. So, sorry, long answer on timeline. Still working to Christmas at the moment, but things are a bit fluid as the new hospital programme works through all of those issues that I've just described. And then likewise on the budget, someone's put in a question here on the chat saying they've heard a rumour, I guess, that reading the trust board notes that the trust have been asked to trim back plans from the previously suggested 540 million in Watford and 20 million Hamel, 20 million St Albans. Now those numbers are not exactly right, but they are broadly where we were in the regulator letter. So that isn't quite right, and if that's how the notes from the board have been interpreted, I need to go back and just have a check that they're, I think, accurate from the discussion that we had. We are currently working through the costs of that range of options that I've described, and it is clear that a new build option for emergency care on the Watford site will be more expensive than the 540 million set out. We are in a dialogue. We've done a first run of costs, but they're by no means finalised, and we're still working through a lot of detail at the moment. And there is this kind of continuous challenge, both from ourselves to ourselves, but also from NHS England and the new hospital programme to say, are you absolutely confident that you've got your preferred option really clearly defined in terms of the services, the right amount of space, not too much, not too little, the right costings in there, and clearly there's a challenge for the country, for the Treasury, for the Department of Health to fund 48 hospitals, but we're absolutely, at the moment, we're focused on getting the right solution and being absolutely robust in our costing methodology, and we haven't, we effectively at the moment there's no set number that we're working to, which is quite nice compared to the set number of 350 million that we were working to in 2019. But clearly we are going to have to demonstrate that whatever option we put forward is affordable, both for us locally but also for the NHS more broadly. So watch this space. We're not quite ready because we're still working on it effectively to say how much the investment's going to be, and we will set out our preferred option. I do expect to say basically a new build emergency care facility, but there will be options then in the appraisal which are not quite a full new build that cost a bit less, and then there'll be a discussion with the new hospital programme and regulators to say what's genuinely the right solution. But I think Freddie will corroborate me on this, certainly for emergency care, we do think the benefits of new build are really, really significant, and that we will continue to kind of advocate for that to get the best solution that we can. So it's 1 minute to 2. I don't know if Freddie does want to say anything, or Esther by way of any closing remarks, but I think I've covered all the questions in the chat. I'm not seeing any waves to come in, so suffice it to say then, thank you all very much for joining us. Oh, sorry, someone's just come in. 20 million, Clch and Hamel. No, we do expect still to invest in plan to care on Hamel, Hempstead and St Albans site. Again, exactly the same position as for Watford, really, in that we're still working through the detail to get there. We expect at least that level of investment in Hamel, Hempstead and Clch, if not slightly more. But it is all dependent. What we ask for is not necessarily what we will get. So we will be asking for what we think is the best solution overall. So on that note, I am going to say thank you all very much for joining us. There are more opportunities to join us coming up, and do let us have your views through that link. Thank you all very much.